So our next presentation will talk about PNH, and my pleasure to present the next speaker is Dr. Ashraf Warsi. He's a well-known consultant of adult hematology at Princess Noor Oncology Center, King Abdulaziz Medical City, National Guard, Jeddah. He is interested in thrombosis, bleeding disorder, and MBNs. He's certified American and Canadian Board of Internal Medicine and Adult Hematology. He completed his clinical thrombosis fellowship from McGill University, Montreal, Canada. Please welcome Dr. Ashraf.
So, Assalamu alaikum wa rahmatullah. Thank you very much for the kind introduction, and thank you for organizing a scientific committee for inviting me to the meeting. Just one disclaimer, as you heard, I'm not a transplanter, so be gentle with the transplant questions for me. In the next probably 20 minutes, I'll be going through a bit of introduction about PNH. The complement system and the pathophysiology of PNH, I think this is one of the fascinating diseases where if you understand the pathophysiology and see how the drugs have been developed, it's really amazing developing targeted therapies for this disease. How patients present, what signs they have, and how do we screen and diagnose these patients. And finally, the bulk of the talk will be on the treatment options for these patients. So, just writing up ultra-rare disease. So this ultra term, I was really reluctant to use it. I found it in one of the articles mentioned, but yes, it's quite rare to see PNH. And in the next few slides, you'll see why some centers describe they have more than 1,200 patients of PNH, and why some centers describe we have only like 2 or 3 patients. I've been in National Guard for the last 13 years, and I've treated only 3 patients. So it's pretty rare, and we're a referral center, so it's pretty rare to see patients. So it's an acquired mutation of the clonal hematopoietic stem cell. The mutation happens in the PIGA gene, which is present on the X chromosome, and basically responsible for production of the GPI proteins on the cell surfaces. It's characterized by complement-mediated intravascular hemolysis, leading to thrombosis, and occasionally with bone marrow failure. So, mainly adults, around 30s, are usually affected or diagnosed with the disease. Its incidence really varies from center to center, and what are they using to report it? Are they using a positive clone, or are they using actually a PNH patient with either thrombosis or hemolysis? So 1 to 10 cases per million population. What do we have in local data? Really not available, but take what I'm saying with a grain of salt. In the GCC area, we have around 75 to 80 cases. This is from actually the supplies of ravlizumab, and we have 5 other patients on other treatments. So the whole GCC countries have around 85 patients in total. Male and females are affected equally. So the complement system and the pathophysiology of PNH. As you can see from the graph, so the complement system gets activated either through the classical pathway, lectin pathway, or the alternative pathway. All 3 pathways eventually go in to do the C3b amplification loop, which forms the C3 convertase, of course, first. And that cleaves C5 into C5b, forming the C5 convertase, and eventually forming the membrane attack complex. So unfortunately, I don't have a pointer here, but so those are the basic complement pathways. And what prevents the formation of these or protects the cells are basically the CD59 and CD55, which are basically the GPI anchor proteins. So what happens in the disease, when you have absent CD55, basically CD55 inhibits the C3 convertase, and the CD59 inhibits the incorporation of C6, 7, 8, 9, and formation of the MAC. So though you miss these in the patients of PNH, and that promotes basically hemolysis. So once hemolysis happens, what happens next is basically you get your LDH high, of course, just from the hemolysis, but with release of free hemoglobin, which is a scavenger of nitric oxide, that will lead eventually to end organ damage in the form of you get chronic kidney disease just from the hemolysis and injury to the tubules in the nephrons. You get pulmonary hypertension from chronic scavenging or decrease in nitric oxide and vasoconstriction. Liver damage from recurrent transfusions also can happen. Early gallstones can happen. From the nitric oxide decrease, you get smooth muscle dystonia, so you develop dysphagia, dyspnea, erectile dysfunction, occasionally chest pain as well. And with the activation of leukocytes and platelet activation and release of fibrinogen cleavage and platelet aggregation, you develop thrombosis as well. So you can thrombose and hemolyze all together, leading to, and thrombosis usually, I'll get into the more slides where common sites of thrombosis that happens. So the common symptoms that the patients present are fatigue, probably related to anemia, dysphagia, dyspnea, chest pain, abdominal pain, hemoglobinuria from the name of the disease, and erectile dysfunction. So around 16 to 46% of PNH deaths were due to venous or arterial thrombosis. Used to be the leading cause of death for these patients. Around 2 to 18% will have chronic kidney impairments, and 47% of patients will have some degree of pulmonary hypertension. So it's a quite multi-system disease, in fact. Oh, well, good as a timer, actually. So this is an important slide. This is the UK group, and if you've heard the people from Leeds, which lead the city is Leeds, but they also lead the national PNH services over there, they're going to tell you they have around 1,200 patients registered, and it doesn't make any sense from the data or from the numbers I told you, the GCC area. But basically what they're describing is this. So this is basically any clone above 0.01% they regard as a PNH positive clone. And when they looked at these 172 patients, 65% of them had cytopenia. So probably those were your MDSs or the aplastic anemia patients. 28% had the hemolysis. MDS are separate, and thrombotic patients were very rare to be seen in this cohort of their patients. So if you regard all the patients, and they do this, so they follow basically all PNH clone patients regularly, not necessarily treating them. It's depending on the underlying cause of the PNH clone. There's an overlap of PNH and bone marrow failure syndromes, and that goes back to their pathophysiology. So in aplastic anemia, which we just heard a wonderful talk about it, you get these T cells which are basically attacking your bone components, and because of the absence of the GPI anchor proteins on the PNH cells, these T lymphocytes do not attack or cannot attach to these cells, so they have this survival advantage. They do not proliferate, but because the marrow gets empty, they basically start occupying, and your PNH goes up in severe aplastic anemia with time. And that's what we have seen. Similar things happen with the hypoplastic MDS patients. So how do we classify them? So the classification is basically subclinical, I'll start from down, but basically one group is the subclinical PNH clones. So these are small clones that are not causing any symptoms or signs on the patients. And the other type is basically classic PNH, and what we mean by that, these are the patients who either present with hemolysis or thrombosis or both together. And the PNH type clones present with a defined bone marrow disorders, mainly severe aplastic anemia or MDS. So not all patients will behave the same, even if they have the similar clone percentage. So the differences is basically due to different or multiple occupied mutations in the gene of the PIG-A gene. So the grade of GPI absent proteins on the cell surface, they divide them into type 1, type 2, type 3 cells, and basically type 1 are the normal cells. Partial depletion of GPI anchor proteins is type 2. Complete absence are type 3. And your flow cytometry lab can actually classify these cells on their reports. Symptoms by percentage of GPI, certain symptoms are more common with type 3 cells compared to the type 1 or type 2 cells. For example, hemoglobinuria, abdominal pain, or scleral icterus are more common to be seen with patients who have type 3 cells. Similarly, LDH concentration, if your LDH is above your patients is above 1.5 upper limit of normal, you're more likely to have, again, hemoglobinuria, dyspnea, scleral icterus, abdominal pain, chest pain, and dysphagia. These are more common and probably related to more active hemolysis in these patients. So are they at risk of thrombosis? Yes, definitely. So probably risk of thrombosis regardless of the percentage of or the type of PNH cells, it ranges from 16 to 20%, so it's quite significantly high percentage. And if your patients have symptoms and elevated LDH, the associated risk for VT really goes up. So for example, if your patient has abdominal pain and elevated LDH, then the odds ratio of developing thrombosis is 17.8, much significantly higher than if he had a normal LDH. And that really drives one of the monitoring of these patients on therapy is basically trying to get the LDH less than 1.5 upper limit of normal. So the common sites of thrombosis in these patients, of course, DVT is the commonest one, followed by the splanchnic or mesenteric vein, followed by the hepatic or portal veins. So occasionally you see voido-occlusive disease or VODs, cerebrovascular accidents, and occasionally, much rare, but have been reported, the myocardial infarction and unstable angina in these patients, or what we call as white PNH. Take it with a grain of salt, but this is basically looking at the risk of different thrombophilias, comparing it to them. So the factor V-laden heterozygous is the highest risk of thrombophilia, and probably PNH is really close to it. So this really emphasizes the importance of monitoring them or treating thromboembolism in these patients. This is an old graph, so this is before the era of complement inhibitors, but basically tells you if the patient had thromboembolic events or if they had cytopenias, impaired renal function, or elevated LDH, their survival was significantly lower than those patients who didn't have it or compared to the general population. So what are the core signs and symptoms, and which patients should be screened for PNH? So symptom patients usually, as I mentioned, have symptoms of anemia, fatigue, shortness of breath, headache. They may present with unprovoked thrombosis, dark urine, intermittent abdominal pain, or may have smooth muscle dystonias, for example, dyspnea, dysphagia, erectile dysfunction, abdominal pain, or chest pain. So they divide them into different categories. So bone marrow dysfunction, if they have unexplained cytopenia, and any of the following, whether they have refractory iron deficiency anemia, non-responsive to therapy, or thrombosis, they probably should be screened for PNH. Aplastic anemia, all patients diagnosed with aplastic anemia should have a screening for PNH, looking at the clone size and monitor regularly. MDSs, if they are hypoplastic or refractory cytopenia, then they should also be screened. Unprovoked thrombosis with any cytopenia or hemolysis should be screened as well, and sometimes even without. So I basically screen all patients with unprovoked thrombosis for PNH. Coombs negative hemolytic anemia has to be done, and one of our patients, basically she's a female patient diagnosed 3 years ago, and her main presentation with hemolytic anemia, which was Coombs negative. Hemoglobinuria also deserves a screening for that. So what the labs does basically, and the recommendations from the International Clinical Cytometry Society, is doing 2 assays. One of them should be the FLAIR assay, which is a fluorescein-labeled aerolysin enzyme, which basically binds to GPI anchors, and if they're missing, basically you get negative tests for that, plus a CD55 or 59 on red cells, or doing a CD157 on granulocytes. And you need 2 different cell lines, so commonly we do granulocytes and monocytes and red cells looking for these anchoring proteins. So the initial evaluation, detailed history, and physical examination are important, but the laboratory workup should include a complete hemolytic workup with a test for organ dysfunction, including renal, liver, cardiac, if available, BMPs, and bone marrow evaluation with cytogenetics. And of course, importantly, you do virus serologies and nutritional panel. Also, if you have available echocardiogram at baseline with an ultrasound abdomen with Doppler and pulmonary CT scan if suspecting pulmonary hypertension. So the treatment. So subclinical PNH, supportive care, which is basically based on nutritional supplementation. They do not hemolyze, so they don't have anemias, and regular follow-up for these patients. Classic PNH, which are basically hemolytic or thrombotic, we'll be discussing them later on. With the patient PNH type clones in patients with bone marrow failure disorders, treatment is usually directed to the underlying bone marrow disorder. So the treatment, we have 2 types. We have terminal complement inhibitors and proximal complement inhibitors. So as you can see at the bottom there, we have the terminal complement inhibitors, the C5 inhibitors, and these include eculizumab, ravulizumab, crovalimab. Also recently, there are biosimilars to eculizumab, which have been approved by the American FDA. C3 inhibitors include pegcetacoplan, and the more alternative pathway or proximal inhibitors also include factor B inhibitors, iptacopan, and factor D inhibitor, danicopan. So the TRIUMPH trial was basically a 2006 randomized trial which looked at the eculizumab in patients with PNH, and at that era we only had supportive care for these patients, so transfusion as needed, management with hydration when they presented with renal impairment and acute hemolysis. And in fact, at that point, eculizumab really changed the landscape of these patients. So hemoglobin stabilization was established in half of these patients, and transfusion independency, 51 patients, which was really unheard of, and became the standard of care since that time. There was also much improvement in patient-reported fatigue scores. So it became the standard of care. And later on, ravulizumab, which is again based on the molecule of eculizumab, was introduced. And in this trial, which was basically included 246 complement inhibitor naive patients, patients were either randomized to eculizumab, which is given intravenous infusion every 2 weeks, versus ravulizumab, which is given intravenous infusion every 8 weeks. So significantly decreasing the number of visits. Not only that, but it was also much, this was a non-inferiority trial, and it did reach its goal, and it showed very much significantly, and it did replace eculizumab in the treatment for PNH. They also did the second study looking at, so those were naive patients randomized, but here what they did basically took around 195 patients who were on eculizumab and randomized them to either receive eculizumab or ravulizumab, and it was a non-inferiority trial, and they did reach their goal, so it was very similar to eculizumab, but better tolerant and better compliance with the patients. Second came the third medication in the terminal complement inhibitor is crovalimab. I don't think we have it in the kingdom here, but it has very recently, I think 2 years ago, approved by US FDA. And it is it's similarly what they did, and it was basically in the Commodore 1 study. They looked at patients who were on eculizumab versus crovalimab, switching them to either crovalimab or eculizumab, and it was a non-inferiority trial, and it showed it's tolerated very well. It's given every 4 weeks injection, so again, decreasing the number of injections. Similarly, they also did a naive patients, randomized them to either eculizumab and crovalimab, and it did very well in that, and it was a non-inferior to eculizumab, so that's where they got it approved. So was that the end of the story, and why did we need to develop proximal inhibitors? So that takes us just to define a little bit of the common terminologies in the literature of hemolysis in PNH. So there's intravascular hemolysis, there's extravascular hemolysis, and there's breakthrough hemolysis. So what do we mean by that? So in your left-hand side, the PNH untreated patients, they're missing the GP anchor proteins, and the C5 gets activated on the surface of red cells, formation of MAC, and you get lysis, which is the intravascular hemolysis. When you block the C5, that really blocks the terminal pathway, so no more MAC are produced, but the C3b is still laid over the red blood cells, and these basically cause opsonization of the red cells, and they get recognized in the reticuloendothelial system, in the spleen and liver, and get hemolyzed. So this is what we call as extravascular hemolysis in these patients. What about the term breakthrough hemolysis? So breakthrough hemolysis is basically when the patients on treatment get any stresses like, for example, pregnancy, infections, vaccinations, that causes the stress on the complement pathway. And in these scenarios, probably due to the hyperstimulation, some of the C5 get through, and they form hemolysis in these patients. So that's what we call as breakthrough hemolysis. How you differentiate between extravascular hemolysis and intravascular hemolysis, this is what what is published. Clinically, I would tell you it's really difficult, but basically it's a patient who is doing very well on therapy, but on terminal inhibitors, and you find that persistently they're having low hemoglobin. Some of them may be symptomatic, some of them may be asymptomatic. Probably after 6 months of therapy, and if they're symptomatic, you need to change therapy or add on, and I'll tell you in a minute what are the drugs available. So that was behind the extravascular hemolysis issue, the development of the proximal complement inhibitors. And the idea was if you block earlier on, you lose the C3b opsonization red cells, and that would prevent the extravascular hemolysis. So pegcetacoplan, available in the kingdom, the Pegasus trial, which looked at basically adult patients with PNH and persistent anemia, despite more than 3 months of stable eculizumab. It was a 16-week trial, and it showed that patients were randomized either to continue eculizumab or switch to pegcetacoplan. It showed an increase of 3.84 grams per deciliter in these patients. So that was a very significant increase in this patient. The other trial with the Prince trial, which was a single-arm study looking at naive patients with PNH, it's a 26-week study, and showed remarkable improvement. But remember, this was just a single arm of patients, so it wasn't comparing to eculizumab. So it did show that well. And from that, it got approved for treatment in PNH patients, and probably it has the potential of being the first line of therapy. The only issue with it is given twice weekly. So that's one of the issues with it. Oral iptacopan, the APPLY PNH and APPOINT PNH trials. So similarly, iptacopan is a factor B inhibitor up in the cascade of the alternative pathway. Here, they looked at patients who were receiving eculizumab or ravulizumab, having persistent anemia, and either the arm was switching to iptacopan versus just continuing on the terminal inhibitor. And it showed significant improvement in hemoglobin, so around 82% of patients had increased their hemoglobin by 2. Transfusion avoidance was achieved in 95% of these patients, so significant improvement with it. Favorable safety outcomes, so no adverse events were looked at. Common were diarrhea, nasopharyngitis, and nausea, which we see commonly when we use complement inhibitors. Ravulizumab or eculizumab in patients. So the later drug came in, the factor D inhibitor, danicopan. So it's an add-on therapy to ravulizumab. Again, registered and available in the kingdom as well. And we recently, just 2 months ago, added it to one of our patients. So the ALPHA3 phase 3 trial were basically 73 randomized patients to either add on oral danicopan or placebo to a terminal inhibitor. And what they found, their primary endpoint, there was an increase in by 2.94 gram per deciliter in hemoglobin. Transfusion avoidance was achieved in 83% of patients on danicopan. 60% of patients achieving hemoglobin increase more than 2 grams, and clinically meaningful improvement in the FACIT-Fatigue scoring system. So it was very well tolerated, 0 meningococcal infections, 0 deaths, and clinical conclusion was that adding danicopan in patients who are not achieving their goals in hemoglobin. By the way, the anemia on terminal inhibitors, different trials have used different cut limits. Iptacopan used 9.5 grams per deciliter. The danicopan, I think they used 10 grams. So it's a different level of anemia that different studies have used. So what happens to the hemolysis if you're using proximal inhibitors or if you're using combined therapy, terminal and proximal, with a danicopan add-on? So if you're using the complement proximally, yes, you're blocking significantly the extravascular hemolysis, theoretically, but then you have the C5 getting accumulated. So when a breakthrough hemolysis, so you have a stress on the complement system happens, that really causes significant hemolysis. So if one molecule of C3b red cell opsonide passes through, or C3 passes through, it will activate multiple C5 labeled red cells and cause significant hemolysis. And that's what we saw in the trials of pegcetacoplan. Whereas probably the ideal scenario is terminal and proximal inhibition as an add-on danicopan with a terminal inhibitor. So time is running out, so I'll just go very quickly. Breakthrough hemolysis can happen either pharmacodynamically, so this is what I mentioned with the stressors, but it can also happen pharmacokinetically. So in the patients who are only on proximal inhibitors, for example, iptacopan or pegcetacoplan, if you're missing a dose or you delayed in your doses, there's a significant chance that you'll have extensive hemolysis in these patients, just from the pharmacokinetic. And in the eculizumab era, I had a patient which I've seen that just because of availability issues, if he misses the doses for 2-3 days, he would present with acute renal failure from the significant hemolysis. So that's a very important factor to remember. Management of breakthrough hemolysis, there's no guideline for that, but basically this is an expert opinions. More than 4 weeks in last dose, pull dose forward. If it is less than 4 weeks, you have to observe closely. Breakthrough hemolysis on proximal inhibitors, it does happen. So iptacopan, pegcetacoplan, if they were using, ensure compliance, very important. And then probably if they have significant, you can use a single dose of a terminal inhibitor. On the other hand, C5 inhibitors with danicopan ensure compliance, of course, increase the dose of danicopan instead of BID to TID, treat the underlying cause. Allogeneic hematopoietic stem cell transplant, so I said I couldn't present this as SSBMT without discussing some of it. You've seen the severe plastic anemia working party from the EBMT. So they had this report as an abstract in the ASH 2024. Unfortunately, I couldn't see it as a full publication. But basically, they looked at 10 years, so the decade, and a total of 259 patients across 225 centers were transplanted. Male, females were probably equal. Age was around young age, so from 18 to 36. PNH subcategories, so classic PNH was around half of the patients. PNH with aplastic anemia, probably that was for aplastic anemia more, 46% of patients. Donor type, they have around 47% matched siblings. MUDs were around 37%. And interestingly, the match and MUD did better than the mismatch MUD or the haplo patients. Source of stem cells, both bone marrow, peripheral blood, almost equally. Conditioning regimens, mainly RIC, but also there was myeloablative. And eculizumab was there used in only 28.6% of the patients. So the overall survival presented in DODS data at 3 years was 82%. GRFS was around 74% at 3 years, and engraftment was achieved by day 28 in 87% of the patients. And I said it's only an oral abstract, so forgive me not to have more data on that. So future directions, danicopan monotherapy is being under trial now. Pozelimab, so this is a C5 inhibitor that is approved for a disease called CHAPLE, where you have protein-losing enteropathy, thrombosis, and we actually, in the gastro department in our hospital, we have a patient on it. So it's very, very interesting, very rare disease to be seen. So combination of pozelimab and cemdisiran, basically cemdisiran is a small interference RNA molecule that decreases C5 production. Again, very promising data from the phase 3 trial. Nomacopan, again, is a C5 inhibitor with leukotriene B4 dual inhibitor, has been in phase 2 or 3 development. So probably we'll see more options coming in the future. So I'm finishing. So terminal complement inhibitors, eculizumab, ravulizumab, target C5, reducing the risk of thrombosis, stabilizing hemoglobin, improving quality of life, as well as overall survival. And probably that would be your first step of treatment for these patients. Most patients with PNH do well on intravenous ravulizumab administered every 8 weeks, but a subset of patients may develop clinically significant extravascular hemolysis. Danicopan as an add-on therapy to eculizumab or ravi may offer a more complete control of complement dysregulation, especially in the setting of a complement amplifying condition, and the long half-life of C5 inhibitors serves as a backstop against recurrent intravascular hemolysis in cases of missed medication doses. If extravascular hemolysis is unresolved, switching to other proximal complement inhibitors, pegcetacoplan or iptacopan, is an option. Allogeneic stem cell transplant remains an option in selected cases, especially cases with underlying bone marrow failure. And that's just it's a bit also from 2022, but most of these drugs, actually, all of these, most of them except for the others I mentioned, the trial have been approved. And with that, I conclude. Thank you very much.
Thank you very much, Dr. Ashraf, for the comprehensive, excellent presentation. And maybe we can take 1 or 2 questions. Dr. Asker.
Assalamu alaikum. Shukran to Ashraf, ربنا يبارك فيك. Considering that many of the patients with PNH will be enrolled, raise my voice?
Yeah, please.
Because I can't raise my voice at home, so I don't want to do this. So anyhow, considering that many of the patients with PNH will be enrolled on complement inhibitors nearly for life if they are not transplanted. If you face a patient with splenic vein thrombosis or portal vein thrombosis with huge splenomegaly that is exaggerating the cytopenia in PNH patients, would you recommend in this patient population to remove the spleen or do as much as you can to do transsplenic stenting of the portal or splenic vein and continue with a functioning spleen so that you can reduce later on life-threatening infections and complications?
So, first of all, if they have PNH with thrombosis, basically, they're going to need to be on an anticoagulant. And after you initiate your complement inhibitor, whether you really need the anticoagulant more or you just need it prophylactically, some expert will just omit it after 6 months of therapy. Some expert will put it on prophylactic dose if they're on a complement inhibitor. Now, the issue with the huge spleen, I have seen that people who have developed, not PNH patients, but other reasons for JAK2, for example, and a huge spleen, it causes lifelong cytopenias in these patients. Whether I haven't been in a scenario that's significant to say you need to remove it. And by chance, even if they have the splenomegaly and you, by a reason of anticoagulation, revascularize or recanalize the splenic vein or the portal veins, it doesn't go down, it doesn't shrink. I don't know why, but it still remains splenomegaly. Having significant splenomegaly and a different pathology, it may be an option to do a splenectomy in these patients. It's not like a myelofibrosis patient. They do not have extramedullary hematopoiesis, so you don't worry about that. But having massive splenomegaly has its own risk during surgery. I had recently one patient who presenting with pancytopenia and massive splenomegaly. There's one of our expert surgeons told me clearly, first it's going to be an open one, second is a high mortality and morbidity from thrombotic risk, and third, most likely she will go to the ICU. We eventually did a splenic biopsy, and we got the diagnosis on that patient, which is a rare type of lymphoma. So you may consider it, but it comes with its own risks. I would only do it if it really was the last option to do that.
Thank you. For iptacopan, sorry, after...
Chairman has a question, so...
Yeah, okay, after the chairman.
Ashraf, very nice presentation.
Thank you.
Regarding, we always, it's common that we face acute situation in the hospital, you're suspecting PNH, and probably, there is high probability and you might start an agent either to stop an acute hemolysis or renal failure or thrombosis or whatever it is. So you need an urgent intervention. So which, in your mind, among these agents would have an onset of action that's more rapid than the other?
If you have eculizumab, first of all, we're in a good center, it's your sister hospital, so we can get the flow cytometry if it's in the daytime, we get it on the same day, or by mostly within 24 hours. And probably your patient can wait for that if he's thrombosing you anticoagulate, because that's the treatment acutely. If he's hemolyzing, and we see hemolysis in other diseases, for example, G6PD, very significant hemolysis, and we manage them support until we get the diagnosis. And if you get the diagnosis, eculizumab is still available. It's now registered in the kingdom, and it has other uses, for example, in transplant settings. If you have it, that's fine. If you have ravulizumab, it also has a good early onset. So any of these two, treatment, if you have a PNH patient, first-line treatment would be a terminal inhibitor. The breakthrough hemolysis is really a small number in these patients. The issue is the extravascular hemolysis. So eculizumab or ravulizumab, whatever you have available would be there, but I would really check the diagnosis. Remember, I didn't mention it there, but if you're using a complement inhibitor, 2 weeks prior, you should vaccinate your patients against meningococcal, especially. For the proximal ones, you also vaccinate against pneumococcal and Haemophilus influenzae type B. So that's very important to remember. If you're in an urgent situation, then you need antibacterial prophylaxis until the vaccination works. I hope that answered your question, Dr. Asghar.
Okay, thank you. For iptacopan, since it is working on intravascular and extravascular hemolysis, can be used as monotherapy from the beginning or
Yes,
only?
so the trial did use monotherapy from the beginning in naive patients. It wasn't compared to eculizumab, but yes, it's approved, and it is one of the options. Very interestingly, as I mentioned, not all PNH patients will behave similarly. So I heard from a physician in National Guard Jeddah, they have this patient they have exhausted. He was on eculizumab, ravulizumab, danicopan add-on, didn't work, pegcetacoplan didn't work, and they were considering iptacopan. Now, the expert did mention to do that, and I think that eventually patient would be somebody with a PNH who will go for transplant. He's a very young patient as well, in the 30s.
Okay, thank you very much, Dr. Ashraf.
Thank you very much.
We'll go for next speaker.
Okay, thank you. So we'll move on